So thank you for the clarification, and I will talk about full endoscopy, which is what it means. Now there are very many misnomers. Let's go not go into it. So what I will talk about is the full endoscopic technique, and I have been told to talk on endoscopic discectomy. Is it time to change? So let me clarify that just like Vishal, I completely agree. The surgery part of it remains the same. But what we do is we have a better access, maybe a smaller access, and sometimes that access can make a lot of difference. And that is all about it. Rest everything which Vishal told, the technical part, everything we do exactly the same. The surgery part doesn't change. So I have been a tubular surgeon for like Vishal for many years till I saw this beautiful girl and I fall in love with it and started my endoscopic journey. So why endoscopy? This is up close and personal. One of the beautiful thing about is, unlike you're using a microscope, you loop or your naked eye, your vision is away. You are looking at it from away. Endoscopy, the camera, your source, everything is just out there. So it not only it gives you a very good vision, it gives you a brilliant vision, and that's what I call an up close and personal surgery. So there are two ways to do it. One is interlaminar approach. Interlaminar approach is nothing but what you have been listening till now. It is just an extension of your traditional approach. Like it has exactly the same thing what you do with open or tubular. So it is something you are all familiar with. It is a versatile approach, but understand interlaminar window changes as you go from 5S1 to L1, L2. And as an endoscopy surgeon, that sometimes limits you to do your surgery. So something like this, a extruded disc L4-5, it is, you all you have to do is go out there. You don't even have to remove your ligamentum flavum because you go inside the ligamentum flavum and do your job. This is the vision I get. I don't remove, I just cut a small fragment and put my scope inside. And this is the vision you have. You can see the disc, you can see the root, because that is what everyone was trying to do all the time. Why remove the bloody ligamentum flavum or the lamina just to do that part? So that is the beauty of it. You go there, you remove a disc, you see your nerve root, and you come out, job done. So exactly I did was what everyone was trying to do till then. Only thing, because the access we have, it gives me a certain advantages over them, and that is all you have to do. And then, just like Vishal did, just like Vishal so you also make sure that your root is completely decompressed. You have a good decompression, and that is as beautiful as it can get. So, what about something like this? Can you do this endoscopically? So this is like the whole canal is getting filled up by a huge superior magnetic disk. Does it limit your chances to do such case? Of course, the patient has a complete foot drop because not only that, because if you see the disc has migrated and is going up to the L4 root. So this is how she comes. So if you see, this is my endoscopic approach. See how much variation I have. I have gone to the L5S1 disk and I also have gone to the L5 exiting route. You look where the probe is going. And that is the freedom it gives me. So this is the end of the decompression. Not only we can see the exiting route, the dura, but even the traversing route. You just need to move your scope from one end to another. And it is so flexible, so migrated. It exactly allows you to do everything. So, and look at the amount of disk material we removed. It took us some time, but we did do it a complete. And just because you might not be convinced, this is a post-op MRI. You can see we have done a complete job. Patient went on to do well. She did improve at the end of 3 months. Not only that, interlaminar approach allows you to do your discectomy. You can now with the burrs, like anything like Vishal was using a burr, if I need to add a decompression, it is not a problem at all. We can do only discectomy, and if need arises, we have to decompress something, we can use this burst to decompress as well. But transforaminal approach is a different ballgame altogether. All those who have not done this has not seen this approach. It is an approach which goes through the Cambian's triangle, the way they were using to put the dye. It's a safe triangle, and most of you are aware of it. And it gives you a different outlook altogether. So, like as Gautam sir was telling, for something like a extraforaminal disc, it cannot be easy than doing a transforaminal approach. So this is what we use. We go through the Camden's triangle, which is a natural corridor. You go to the spine and you do your job. But understand the limitation of interlaminar was as you go up, it was becoming slightly difficult to do the job. In transfemoral approach, it's the other way around. Because your interlaminar space is less, you are much more suitable to do a higher lumbar level disc. And just to show you a small video, and this was a case of extrafemoral disc. The same thing what Gautam sir was telling. This patient has we tried everything. He didn't improve. He has a list. You can see this L4-5 far lateral disc. He's going and hitting the root up there. It's a huge disc and it's completely displacing, the nerve root. And this is just I think, 2 minutes video. And, this is what you do. You take a 0.8 centimeter incision. You put your dilators, you put your guide wire. Instead of doing it from posterior, you go to the Camden's triangle, and and this is how you go about it. I'll just forward it a bit. And once you put your scope, it's all about target. Just like the way target the root, you need to where you have target. This is how the target sees. This is Siam workflow. Look what I'm targeting. I'm landing exactly where I have to do the job. Once you land there, and if you land correctly, first thing you see is a disc. That's it. Because that is how your approach is. In fact, the disc protrusion lets the root go away from your view. It makes your surgery safer. Because of this prolapse, the root is up somewhere and you're landing below it. So it is much safer to do a transfemoral approach. But not only that, you do a discectomy, you can 100% go and check out the root, how it is. And this is the red inflamed root, which you can see. Once you have done your job, that is the time root comes back. Because all the time it was pushed up by the disc. So disc, which was a problem for everyone who was doing all the Camden's, some will see the approach, blah, 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 is a friend of mine because it pushed the root away and made my surgery safer. So that is all you have to do. You mobilize. At the end of you mobilize the root, you do your discectomy, and a single suture is all that is needed at the end of the surgery. What about something like this? It says high central disc. It is not an easy ball game, no matter who you are, no matter how trained you are. And it becomes something very, very difficult because it has all the risk involved for doing a traditional surgery. Again, my transfemoral approach helps me here. You can just go out there exactly where the disc fragment is. You go there, you see, first thing you see again is a disc, which is a huge disc, which is out there. You take the disc fragment out, and that is how the disc fragment comes out. And this is the huge disc fragment which comes out. And that is the end of your job. You see that you have, and this is the post-op MRI, just to show you. And this is how it looks like at the end of the surgery. Now, not only you do things which you do commonly, this was a patient who was we started in the era of COVID when most of the patients were not fit for anything, GA or anything. And this was a patient of discitis on CKD, some creatinine was 7, 8, unfit for anything. You cannot give GA, you cannot do anything, and huge pus in the pain. And again, we went for a endoscopic approach. And I'll just show you, this is where you go and look at the pus you can drain. It is this like you can really do the job. You can do as much as you need. You can really get your job done. And this goes on for another 3 to 4 minutes. And patient is awake because done in block. We use a erector spiny block for these cases. And not only that, we could, because there was no way we were going to put instrumentation. We did just a draft in that, and we have intraoperative CT, so we can see exactly how it has gone, and it came out to be E. coli. Patient went on to do well. So another case, now if you look at this, it sort of tells you there is something more happening. Not only this is it's a D12L1 disc. Not only is a disc, most of you will say, I think will understand, it is basically calcified disc. And, so to do this, if you were to do anywhere else, it might be very, very challenging. So what we did, we used navigation, and we sort of navigated our endoscopy work. You can see the calcified disc. Again, you look at it. Look at the point of mine where as an endoscopy surgeon, what I see, that this fragment on calcification is protecting me. It is pushing the dura away from me till I remove that calcification. No way in the world I can touch or damage the dura. So that was my plan of going through the transformer approach, and this is what we did. And this is a navigated burr. You go with navigation, you use the burr, and you drill out the hard calcified part first. Till you get that out, no way your dura is coming into picture. You know that for sure. And of course, the navigation helps you. And look at this after this is your dura. And look at the beautiful view you have, a demarcation between the dura and the disc. And you know where you are. You can see the dura all the way once you have, so burred out the whole calcified fragment. And this is the end of the decompression. Look how the dura is fluttering. This is what we call a dura flutter. And that sort of tells the dura have enough space and is properly decompressed. So, nothing comes without a price. This all also has some sort of limitation. The learning curve is substantial. It's not substantial because, it's a great technique. It's substantial because people are not used to it when they are getting trained in their medical college or in the spine training. The cost of instrument also is a problem. And radiation exposure, if you're doing transform and all, it does come into picture. Again, remember, some of the cases might be very, very challenging to do it purely endoscopy. But if you change the way you look at things, the things you look at change. For me, extrafemoral disc is very, very easy. It was very difficult to do that. Even a high calcified disc, I think it's much more easy for me to approach this way because I have made a change in the way I approach them. You know, we started with one scope. I had only one scope with me when we started 4 years back. It was a transformer scope, and we used to do everything with that. It was a nightmare. Today I have 5 scopes. 2 days back, a complete 4K system was donated to us, and now we have complete 2 systems. So just you have to do it, and all limits exist in the mind, and only in the mind they can be overcome. So all you need to do is change your mindset. And thank you so much.